ankles. Now moving on, let's talk about the cranial nerves related to bones. And remember guys, again, in the bones we have 5, 6, 7 and 8. And when we say 5, remember that the trigeminal nerve has a lot of nuclei. The first one we talked about it, which is the spinal nucleus. It's in the medulla and it extends all the way to the bones. All right, and remember the mesencephalic nucleus was related to the midbrain, and then other than that, we have the main sensory nucleus in the pons. You also have part of the spinal nucleus, all right, and then of course the spinal nucleus is also extending in the medulla, all right. So these are the sensory nuclei. We get to see them in the pons. And we have one motor nucleus of trigeminal nerve. It's only in the pons, all right? So the pons, it has your main sensory, main motor, part of the spinal nucleus, brain, all right? So this is the first cranial nerve that is related to the pons. And what you guys know about the trigeminal, it has a lot of function. And I don't want to go into more details about that. The broadly, we can say that it has three divisions. The ophthalmic, which is responsible for the pain, temperature, sensations of this area, and then you have the maxillary, and then you have the mandibular, and then you have only one nerve related to the whole trigeminal, which is motor. It's actually a branch of the mandibular, which is supplying the muscles of mastication. Why you need to know that? Because if we have injury, you need to know what's gonna happen. So if you have injury, you're gonna have loss of sensations. It depends upon the lesion, and that is gonna be if it's in the ophthalmic division or in maxillary or mandibular, you're gonna lose them if you have a problem with the trigeminal nerve. And you can also have problems with reflexes, and these reflexes are the corneal reflex, the sneeze reflex, and the jaw jerk reflex. So if we have a lesion in the trigeminal nerve, these are the things that we're going to lose, plus of course the motor innervation to muscles of mastication. Now moving on from cranial nerve number 5 to cranial nerve number 6, and you guys know that the extraocular muscles, we have extraocular muscles, and they are controlling the eye muscles, all right? So all the eye muscles are controlled by the oculomotor nerve, cranial nerve number 3, except the lateral rectus, LR6, and SO4. SO4 is the superior oblique. It's supplied by the trochlear nerve, and we're going to talk about that in the midbrain because 3 and 4 are related to the midbrain. And the lateral rectus is supplied by the abducent, and that concerns me here because the nucleus of the abducent is here in the pons, because this is 5, 6, 7, and 8, and we are in the pons. And I told you guys this is the reason why we have the facial colliculus. So you can guys have a question in the exam showing you the facial colliculus, and they can ask you in the exam question, and they ask you what label, name the labeled elevation. You will say facial colliculus. They might ask you the labeled elevation is made by what? You will say and the winding fibers of the facial nerve. All right, so what does the lateral rectus do? It is actually abducting your eyeball. So your eyeball can be abducted by the lateral rectus. Yeah, so that's all for now, and we're going to talk about the lesion as we proceed. Now for the facial nerve, okay, so the facial nerve has a couple of nuclei, and I'm sure you guys know them. You know that the facial nerve is responsible for the muscles of facial expressions, all right, and you know that the facial nerve is responsible for the superior salivatory nucleus. It supplies the submandibular and sublingual gland, and I'm planning to make a video for the parasympathetic innervation of head and neck, the 4 parasympathetic innervation, to explain to you guys the glands of the head and neck and those important nerves, and this is one of them, and inshallah I'm gonna have a video for that. And then the lacrimatory nucleus for the lacrimal glands, and then you have the solitary tract. It's for the taste sensation, and we said that if it's already explained in the digestive module videos, that you guys have your tongue, and you have the anterior 2/3 of the tongue, and you have the posterior 1/3. So the taste sensation of the anterior 2/3 is by a branch of facial nerve, and the nucleus that gives those fibers is what we call the nucleus of tractus solitarius. And I told you guys previously that solitary, S and T, is for taste sensation. All right, so the anterior two-third, this nucleus is the responsibility of the chorda tympani branch of facial nerve. For the posterior one-third, it's by the glossopharyngeal nerve, but the nucleus is the same. The solitary nucleus is the same. And we also have here the mesencephalic nucleus, and the mesencephalic nucleus is responsible for the proprioceptive sensation of your face. All right, so these are the functions of the facial nerve. Now, what will happen if we have a facial nerve injury? So you guys, now we are talking about the Pons. We talked about the external features. Now we are talking about the cranial nerves related to the Pons. We're talking about them. We are trying to highlight and talk more about the important things that will be important when we talk about the injuries. Now, what concerns me here is the facial nerve. The facial nerve is a cranial nerve that supply muscles of facial expressions. And in the facial nerve, you guys know that we have upper motor neurons, and those upper motor neurons are the neurons that are bringing the information from your cortex. And the upper motor neurons are most of the time bilaterally innervating both nuclei of cranial nerves, except, remember when we talked about the hypoglossal, the genioglossus muscle, it wasn't bilaterally innervated, so that if you have a problem in one side, you will have a problem in the contralateral side of that nerve. Another thing is that the lower part of your face, is not bilaterally innervated by the upper motor neurons. So what is the take-home message of that? Now, if I have an upper motor neuron coming all the way down to the facial nerve nuclei, facial nerve nuclei is basically group of cell bodies that will give me the facial nerve that will go all the way to supply my face. All right, so this is my face. So I have a facial nerve nuclei, I have a group of cell bodies, and that will give me innervation to this. Now, what's gonna happen is the upper motor neuron of this will go to this side. They will cross. All upper motor neuron, they cross. And the upper motor neuron of this is gonna cross. All right. Now, for the upper part of the face, I told you guys the upper motor neuron bilateral innervate, meaning that if I have an upper motor neuron that's coming from the left side, this is going to feed both nuclei of facial nerve for the upper half of my face. So I'm not going to have any problem with the upper part of my face, but I will have a problem with the lower part of my face, the contralateral lower, because you know that upper motor neuron close. So if I have a problem here, I'm going to lose the control in the lower contralateral part of my lower face. Okay, so in the upper motor neuron lesion, I'm gonna lose control over the contralateral lower face. Okay, now what will happen in the lower motor? I'm gonna come back to upper motor neuron. Now let's talk about them from step by step. If I have good control, I have from both sides, upper motor neuron, they are feeding the facial nerve nuclei. Facial nerve nuclei are giving upper part of the face and lower. This is normal. Let me talk about the lower motor neuron first, because this is easier, and I will come back to the upper motor neuron. What will happen in the lower motor neuron, like I said, in the hypoglossal nerve, if I have a problem in the lower motor neuron, the electricity is cut off. I don't have anything reaching my face. So I'm gonna have ipsilateral loss of everything in half of the face, because the electricity that wants to give the innervation to the whole half of the face is cut off. So I have ipsilateral loss of control in my face if I have lower motor neuron lesion. What does that mean? What does lower motor neuron means? It means if I have a problem to the facial nerve or its nucleus. Okay, so what will happen in the upper motor neuron? Because the upper motor neuron gives bilateral innervation to both sides of the face, if I have a problem with the upper motor neuron of one side, it means this is not feeding them. So remember that I told you each one of the upper motor neuron, let me draw it here, I don't want to ruin this nice image. If I have an upper motor neuron, this one is giving both upper parts of the face, okay? It gives both, but it does not give the lower part of that face. It does not give. So if I have an upper motor neuron lesion, I'm not gonna lose the upper because this is taking over. Thanks to the left side, it's giving both upper parts of the face, but the lower part of the contralateral face is going to be affected. So in the lower motor neuron lesion, I have ipsilateral, half of the face is lost. In the upper motor neuron lesion, I have contralateral, loss of lower face. So again, lower motor neuron, the final electricity is cut off. I don't have anything reaching the same side. But in the upper motor neuron, there is crossing. So the problem is going to be contralateral, but not for the whole face. It's only for the lower. Because the upper part is, thanks for the upper part, the other side, it's giving bilateral innervation. So the upper half of my face is not affected in upper motor neuron lesion. It's not affected in upper motor neuron lesion. Only contralateral lower face is affected in upper motor neuron lesion. So again, lower motor neuron lesion, ipsilateral paralysis of the whole face because the final electricity is cut off. Upper motor neuron lesion, contralateral because the upper motor neuron cross, but only lower face because the upper part of the face is bilaterally innervated. All right, guys? All right, now, moving to the next cranial nerve, after number 7, we have the vestibulocochlear nerve. So we have the vestibular nuclei. All right, so what happens is we're going to talk about the how we activate the vestibular nerve in balance when it's already explained in the ear videos. It's already explained, so I'm not going to talk about that. You can go ahead and watch the ear videos when you need it. But now, once we activate those nerves, we will have the information coming from the vestibular ganglion in the inner ear. All right, so the information is going to come all the way to give the information to the second group of people in the vestibular nuclei. And we already talked about the vestibular nuclei in the pons and medulla. Remember, guys, we have half of it in the medulla and the inferior vestibular nucleus in the medulla. And in the pons, we have the rest of the nuclei. So we're going to give the information to the vestibular nuclei. So once we have them to the vestibular nucleus, they're going to cross to the other side because they want to reach the cerebrum. Not only that, we're going to have information from the vestibular nuclei going to the cerebellum as well. They are going to go to the cerebellum because we need to control the movement. Not only that, we're going to have information from the vestibular nuclei for the extraocular muscles. What are the nerves that supply your eye muscles? There are 3 of them. Oculomotor for all of the muscles except SO4 and LR6. SO4 superior oblique supplied by trochlear. LR6 the lateral rectus supplied by abducent nerve. Why do we need to do that? Because we need to control your eye movement. What's going to happen if we don't do that? We're going to have a problem in the MLF. What is MLF? It's the medial longitudinal fasciculus. The medial longitudinal fasciculus is a longitudinally running axons, fasciculus, group of axons in the medial side. It kind of connects the vestibular nuclei to all extraocular muscles and also to the spinal nuclei so that you can move your eyes together and you can move your head in response to a stimulus together. And it has also outputs from the lateral lemniscus. It has outputs from stuff related to hearing, vision. All right, so you have many inputs into the medial longitudinal fasciculus. Okay, I will come back to the medial longitudinal fasciculus once we talk about the auditory pathway, because the vestibulocochlear nerve is part of my pons and you guys need to understand it. How do we activate the spiral ganglion? How do we fire the stuff in the inner ear? That is already explained in the ear videos, guys. Once we activate them, we have the nerves coming all the way and they need to stop and give their information to the second group of people, which is the cochlear nuclei. And the cochlear nuclei are going to go all the way and cross, forming what we call the trapezoid body. And we're going to see that some of them will cross, some of them will not cross. And then they will ascend as lateral lemniscus. Lateral lemniscus. This is your head, right? This is your ears. The ears are the most lateral thing of your face. So the lateral lemniscus is related to your hearing pathway, the auditory pathway. Okay, so don't forget this information. And then from lateral lemniscus, you need to take the information to the inferior colliculus and the midbrain. From the inferior colliculus to the inferior brachium. For these two, how to memorize them, I have a nice way to help you guys, but that is in the midbrain videos. And then from there, you need to pass by the thalamus, okay, in order for you to get all the way to the auditory area. And I'm going to tell you which nuclei of thalamus is your destination, and that is explained also in the midbrain videos. And then you go all the way to the auditory area so that you can hear. All right, so this is a brief summary about, and it's very simple and easy thing to remember, because it's basically you are bringing information from hearing, and then you have to go to a nucleus, and then that nucleus is called cochlear, because cochlear means hearing. And then from the nuclei you have a lemnisci, because you guys know in the midbrain we have to transform sensory people into lemnisci. All right, the medial lemniscus was your proprioceptive sensation from the body, lateral lemniscus is your hearing, remember, and trigeminal lemniscus is related to the trigeminal nerve, and the spinal lemniscus was pain and temperature of the ear, remember. So these are the lemnisci, the 4 lemnisci, we have them in the tegmentum of the brainstem. Okay, so once you are there, there will be a small story here, and that is going to be explained in the